Good afternoon. This is Year-Farouc Jaffer from Boston, Massachusetts. It's a delight to present today as part of the Cardiovascular Innovations 2020 on-demand sessions, our review of CTO PCI publications in the last year. I'm very thankful to Dr. Berlakis and the organizing committee for inviting me to do this. My disclosures. So our outline for today is to really discuss clinical outcomes, publications that affect our performance of CTO PCI, looking at randomized trials, meta-analyses, observational studies, as well as discuss two society statements. We're going to then also focus on pathophysiologic insights, and we're going to look at technical advances. And we have 10 minutes to do this, so we'll move fairly fast. Just to start off as a foundation, we could not present our last years of clinical trials without considering the Ischemia Trial and what the implications are for CTO PCI. So this landmark trial was performed of nearly 5,000 patients and had the overall finding that there was a similar cardiovascular death plus MI plus hospitalization endpoint between the conservative arm and the invasive arm. There was, however, very limited information on CTO PCI that could be gleaned from the primary manuscript. Likely the performance of CTO PCI was low in this population. It was not clear that there were dedicated CTO PCI centers. We also do not have full information about incomplete revascularization. One of the also notable findings of this trial was in the supplement, where they discussed what I perceive as a real negative bias towards performing CTO PCI. Statements here really specifying that Cabbage was preferred for situations such as complex CTOs, and that CTO PCI really had to be done at centers which had a greater than 70% rate and a low complication rate, otherwise recommending Cabbage. So in many centers, this is usually not the success rate, and we therefore have to wonder that CTO PCI was not performed very frequently. What I take away from this is that really, as shown here in the bottom graph, that when patients have significant angina, PCI is going to be helpful above conservative therapy. You can look at the change here relative at month 3 and 12 between the invasive arm, the conservative arm. If one starts off with a low angina score suggesting significant angina, the invasive arm is going to perform better. This is consistent with the Euro CTO and Impactor CTO trials. So I think this is what we can glean from CTO PCI at this stage from the Ischemia Trial. What's happened to contemporary adoption in the last several years? Othman et al. Looked at the CTO PCI performance in the BMC2 registry in Michigan. They looked at 210,000 patients, and approximately of these patients, 7,389 or 3.5% had CTO PCI performed. The rate of PCI did increase from 2010, where it was 2.7% to 4.5% in 2018, so about a 50% increase. However, the success rates only modestly improved here, really from 45% to 55% by the end. MACE rates were similar, but this tells us that really greater adoption expertise are needed to have dissemination of CTO PCI techniques across the country. What about the learning curve? Why does it take so long? It does take some time to become skilled, as we know. This was a analysis done from the NCDR from Michael Young and Bobby Ye and colleagues, where 94,000 patients who had CTO PCI from 4.3 million were analyzed over this 6-year period. New operators were defined as those performing less than 10 CTO PCIs per year. And they looked at, in comparison, they looked at a total of 71,000 cases performed by 7,250 operators for new cases. And what they found is that the overall success rate was still on the moderate side at 61%, and the MACE rates were reasonable at 4%. As volume increased, success rates did improve. However, interestingly, at the expense of major bleeding. This is likely due to tackling harder procedures requiring larger sheets, such as femoral sheets. However, it does raise the question of whether or not, given the importance of bleeding, whether or not biradial and ulnar accesses might be more important to consider going forward. Well, fortunately, we actually had some data for this also appear last year in CCI from Paletti et al., looking at, in an observational retrospective registry of 5 hospitals, 1,900 patients, comparing the success rates for an all-trans wrist approach versus a approach that incorporated one of the femoral arteries. And one can see here with lower JCTO scores, 0, 1, 2 to 3, 4 to 5, also studied that really success rates are fairly similar. These are likely to be underpowered here at just 13. I expect at the higher JCTO scores, but in general, for the vast majority of cases, a fairly similar success rate. What about bleeding? Well, not unexpectedly, bleeding rates went down in the fully trans wrist approach, vascular complications, and a trend towards major bleeding. So therefore, there really is this potential benefit, as we know, when we perform biradial or ulnar-based approaches, that we can reduce bleeding, and that is important prognostically, most likely. An interesting paper was presented looking at a potential update to the hybrid algorithm. The hybrid algorithm has really governed our field. This is just a reproduction from JACA 2019, but Dr. Berlakis and colleagues published this many years ago, really focusing on how we might approach antegrade versus retrograde processes and whether or not we use dissection reentry strategies based on the anatomy that we are faced with. In Japan, another study was performed looking at contemporary PCI performed in Japan, 5,800 patients over 4 years. Technical success rate in this population was very good at 91%. Their focus here was really to look at the guide wire manipulation pipe, strategizing here between antegrade and retrograde based on typical features, whether or not there was interventional collaterals. Some features such as reattempt were a little more subjective in terms of our appreciation of how necessary that is to consider retrograde, longer lesions, and then ambiguity or no stump. When an antegrade approach was concerned, rather than looking at lesion length or other features such as the distal target, the guide wire manipulation time was really a focus point. And in this point, looking at the 20-minute approach really allowed them to understand whether or not they should move further on into other antegrade approaches, and really considering in Japan processes that we don't really use that often, which are parallel wiring and IVUS-guided reentry. This was really a flowchart that they are looking at to understand whether or not another version of the hybrid algorithm, another iteration, might be more successful. We do believe that this might undervalue the controlled ADR approach that has been shown to be quite efficacious in US studies, but has to be incorporated sooner rather than later before hematoma formation occurs. On our next topic is looking at the form of intravascular image guidance. What happens for pulled RCTs? Looking at stent optimization by IVUS, we now know from multiple randomized trials of complex PCI that many lesions that are more complicated, longer, for example, do much better for long-term outcomes for revascularization. Well, looking at a pooled of 4 trials and looking at CTO IVUS in particular as the dominant feature, 231 patients, if we looked at patients who met the stent optimization criteria of a mean stent area of greater than 5.5 square millimeters or greater than 80% mean reference luminal area, that we saw that there was literally a halving of the triple of the TVR rates. That is, if the criteria were met, there was if the criteria were not met, the MACE rates nearly tripled here. And this is shown here very early on, but progressing as well throughout the stent optimization group. Older age, longer lesion length, and smaller diameter were negative predictors of not achieving criteria. Therefore, we would say that meeting IVUS criteria is really an important goal, but using IVUS in general should be the main takeaway. What about CTO PCI outcomes in post-Cabbage patients? Dr. Berlakis, Dr. Megali, and their group published recently a contemporary look at what happens to patients who have undergone prior Cabbage when they come to CTO PCI. They looked at 4 observational trials, performed a meta-analysis of over 8,000 patients over 20 years. Patients who were post-Cabbage, not unexpectedly, were older, male, had more complex lesions, more calcified lesions, and longer lesions. This ultimately led to higher uses of the retrograde procedure, lower success rates, more contrast, longer fluoroscopy times, and a higher complication rate, both in-house mortality nearly tripled, perforation doubled, myocardial infarction 2.5-fold. Similar incidences of acute cerebral events and vascular complications, lower incidence of cardiac tamponade. So again, reinforcing that the post-Cabbage population is a complex population. What about subintimal versus plaque-based CTO PCI outcomes? Walsh and colleagues performed this study, the consistent CTO study, and looked at OCT of subintimal stents versus intraplaque stents at 12 months. Of 231 patients, about 50% were subintimal and 50% were intimal. In those that underwent subintimal-based stenting, dissection reentry techniques, these patients were typically had higher post-Cabbage frequencies, higher stent length, and higher JCTO scores. Interestingly, by OCT, there was no difference in OCT healing strut coverage, approximately 91% in both arms at 12 months. Another sub-analysis was that patients with diabetes did actually do poorer. That's not unexpected, but pretty dramatic, almost a quadrupling of MACE rates at year 1 and a tripling of MACE rates by year 2. And a 15% TVR rate despite image guidance and using next generation stents. So our diabetes population is still quite vulnerable in CTO PCI, and greater improvements are needed, particularly for that population. What about the clinical outcomes of stenting in general? This again shows us contemporarily what our performance is of everolimus-eluting stents. This was the expert CTO trial reported by David Kinsari and colleagues. And one side here that the 4-year-old TLR rates were approaching 11%, 7% in year 1, and about 1.2% per year thereafter. The overall target lesion failure rates were 23.4%, included cardiac death, target vessel revascular MI, and TLR. So this is still a fairly high number. It gives us an opportunity to consider how to do better. One way, definite stent thrombosis was 1.7% at 4 years. But one important note is that IVUS use was less than 10% in this trial. We now know from the CTO PCI trial and earlier data just in this talk that we can reduce TLR rates by 50% using IVUS. This is clearly something important to consider when we are performing CTO PCI, to really use image guidance to optimally expand those stents. What about periprocedural MI? This is a controversial topic, both from the Excel and Ischemia trials. It's certainly not particularly well studied in the CTO PCI population. What is the threshold for actually increasing mortality? And while we have prior data based on CKMB, we have limited data based on the high sensitivity troponin era. So this was a prospective study of 3,700 patients who underwent serial troponins at 6, 8, and 24 hours. And a 2-year median follow-up, a troponin that was 18-fold greater than the upper limit of normal was significantly associated with a doubled mortality here. So we can see here, both as we get into this is going up after we get our threshold at 18-fold upper limit of normal. Here are the Kaplan-Meier curves. So a significant mortality. We really should be focusing on preserving major branches, avoiding long ischemia times and retrograde procedures to reduce periprocedural MI. A high periprocedural MI here again showing the risk of mortality increasing. On another pathophysiologic assessment, perforation analyses. A perforation analysis has really been long overdue, and Taishi Harai and Aaron Grantham and colleagues performed this and published in JACC Intervention last year. 1,000 patients in the open CTO trial in a core lab adjudication found a 9% perforation rate, with about half of those clinically significant. Well, which ones actually cause severe MACE, such as death? Well, it turns out if you look at this, that there were several large antegrade-based perfusions when there was a large amount of volume here, greater than 300 millimeters cubed. There was a significant chance of death here, 2 deaths in the antegrade. But interesting, in the retrograde arm, that 2 of the actual deaths were due to antegrade perforation. We suspect probably in areas of proximal cap ambiguity or severe calcification. But in the retrograde arm, there was 1 death even from a septal, and then several deaths from epicardial collaterals, particularly in the circumflex territory. These are, again, some of our highest risk, and they should be reserved for true expert CTO centers that have the ability to manage perforations with coiling and other maneuvers. Perforations that did cause maze were larger in size, more proximal or at a collateral location, and had a high-risk shape, for example, cloud-like and floating. I will finalize the clinical section by just mentioning there were two really good documents to look at from the last year. Dr. Balakis' document for really guiding principles for CTO intervention, really emphasizing the importance of ischemic symptom relief, specific training required, meticulous stent optimization, and detailed other recommendations were provided here, as well as the new SKY position statement on optimal PCI interventional therapy for complex coronary disease that Rob Riley presented recently at SKY and published in CCI. We'll close with just one pathophysiologic and then two technical demonstrations. What happens to blood flow after CTO PCI? We, of course, would expect that to go up, myocardial blood flow, but doesn't matter by strategy. This is an interesting study from Schumacher and Knappen and colleagues published in Circ Interventions last year, showing baseline and 3-month follow-up PET absolute myocardial blood flow measurements and coronary flow reserve. And it turns out that does not matter between strategy, antegrade or retrograde, dissection reentry, or wire-based strategies. Both myocardial blood flow and coronary flow reserve increased similarly. But in the dissection reentry subgroups, and these are underpowered most likely, but hypothesis generating, is that blood flow did improve less with STAR as well as with knuckle ADR compared to crossboss ADR, suggesting that the ability to really lose multiple branches as we recanalize the distal vessel is greater in the STAR-based approach or knuckle ADR approaches, and perhaps should be avoided over more controlled dissection, such as crossboss-based ADR. One technical advance that was looked at further in the field is antegrade fenestration reentry, AFR, and there were some refinements. Antegrade fenestration reentry has the goal to try to create fenestrations at the distal cap, where then a second system using a wire can then wire those fenestrations and end up in the true vessel. This was presented several years ago from Carlino and Azzolini and colleagues, and Dr. Azzolini presented a refinement study in CCI earlier this year. Some of the failure mechanisms, such as, for example, inability to bring the guide wires closer, were overcome with techniques like dual lumen catheters, where then a wire could be brought very close, and then a second port could be used to wire the fenestrations. Larger balloons 1-to-1, and then escalating from moderate polymer jacket stiffness guide wires like the Xi'an Black towards stiffer guide wires such as the Pilot 200 Gladius Mongo, as well as considering Ketting balloons were used in this new series. In addition, the guide wire shape, which was now 2 millimeters, 45 degrees, was a more favorable shape for reaching into those fenestrations. And then finally, looking at abilities to aspirate dissection to improve this also helped. Of course, a caution was to avoid near major branches, small vessels, tortuosity, and severe calcification. So this is a selected study. With that approach, the success rate approached nearly 2/3 of the population, and in that there was a really excellent overall technical and procedural success. So this can be started to incorporate it as a way such as facilitated ADR, the ability to make cracks in the microcap, side base, and so forth. These techniques can be extended into the AFR domain, and this can be a potential opportunity, certainly in bailout situations before considering high-grade epicardial circumflex collaterals. This would be a very reasonable approach to consider. And then finally, one technique from Minvo and Aaron Grantham and colleagues published in CCI was a way to reduce hematoma in antegrade dissection reentry, which is a failure mode when the dissection leads to compression of the target vessel. For example, shown here in LAD, trying to re-enter this thread-like LAD is going to be very difficult. What the authors recognized is that they had the ability to take a second microcatheter and place it side by side or just proximal to the stingray balloon and then aspirate to decompress the hematoma. By doing that, this can allow reestablishing now of a caliber that is much more likely to be stingable, selectable for reentry. And you can see here in the bottom that once this large hematoma is conformed, this target vessel is compressed. But when we aspirate that, this can be performed with any microcatheter in a 7 French guide. Now the distal vessel is reconstituted, and selecting into the true lumen is going to be easier. Other hematoma approaches, of course, to just remember are the guide extension for inflow blockage and the aspirate through the stingray prior to sticking before using a second microcatheter. So with that, I'll conclude that publications from the last year really provide new insights into the adoption, quality, pathophysiological, and technical approaches for CTO PCI. Continued learning and training will improve outcomes for CTO PCI operators. Thank you so much for your attention, and please feel free to reach out to me by email or Twitter if there are any questions. All the best. Thank you.